take a deep look at how cardiovascular computed tomography can help your patients. Join one of SCCT's hands-on workshops to get real case experience. With virtual access to reading software, learners interact with image-based cases while being guided by experts. SCCT workshops cover a wide range of topics, such as coronary evaluation, plaque features, grafts, valvular heart disease, transcatheter valve planning, structural heart disease, congenital heart disease, masses, pericardial pathology, and other commonly encountered clinical scenarios. All workshops include case credit and CME. Visit scct.org/workshops for more information. That's scct.org/workshops.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. On today's episode, a friend and colleague of mine, Dr. Sotirios Evangélou, will be taking the reins. Sotirios had the pleasure of speaking with Dr. Daniele Andreini on this episode, a true legend in the field of cardiac CT and interventional imaging. Sotirios and Daniele discussed the recently published expert consensus document for pre-procedural planning of coronary revascularization using cardiac CT. Dr. Andreini is the lead author of this expert consensus document. This episode is jam-packed with info on the utility of cardiac CT in extensively calcified plaques, chronic total occlusions in myocardial perfusion imaging, FFRCT, and more. Well, let's go ahead and tune into that conversation now.
Hello, I am Sotήρη Evangélou, a consultant cardiologist at the Diαβαλκανικού Medical Center of Thessaloniki, Greece, and the first committee of SCCT. And here we are with Professor Andreini, a real pioneer in the field of cardiac CT, and discussing about the recent consensus document of pre-procedural planning of coronary revascularization by cardiac computed tomography. So, Professor, a pioneer, as I said, but you can still introduce yourself.
Yeah, thank you very much, Sotirios. So my name is Daniele Andreini. I'm a professor of cardiovascular disease from Milan University, and I'm director of a division of cardiology and cardiac imaging at University Hospital Galeazzi Sant'Ambrogio. I am a cardiologist and radiologist.
Very nice, Daniele. So CCTA has a high diagnostic accuracy for detecting CAD, and furthermore can play a pivotal role in the management of patients with low to intermediate pretest probability for coronary artery disease. However, in more complex cases, it is still regarded as insufficient. This new consensus document of yours has emerged in the right time, I must say, with the recent advances, such as improved temporal and spatial resolution or capability of calcium removal by dual energy CT. What is the rationale for the use of coronary CT angiograph for planning coronary revascularization, Professor?
So I fully agree with you. So in one end, the technical improvement in the last 10 years in the field of cardiac CT, in the spatial and temporal resolution, but also in tissue characterization, allows to a little bit overcome some limitation related to bemodeling artifacts, for example, in calcific lesion. But on the other end, we have the functional method developed from CT FFR and perfusion that allows also to add functional information to the anatomy. And finally, what is important to underline is that some historical weakness of the method, for example, the high-density artifacts, particularly related to heavy calcific lesion, may become a plus, a benefit for planning interventional procedure because, as you know, the invasive coronary angiography is limited in terms of depiction of the presence, of the extent, and of the distribution of coronary calcification. And this may be a strong advantage if you have a roadmap of a calcific lesion by CT. But CT may also provide the intervention with other information that may be useful for planning procedure. For example, to identify the true normal to normal, to characterize the plaque, to avoid to land the stent in a fully lipidic plaque, that this can lead, for example, to complication. Or to know well if there is bifurcation lesion, what is the status, for example, of the ostium of the collateral branch. So many information that can help the interventionalist in planning the procedure.
A little more about the CT-FFR, which is nowadays an established method that allows non-invasive estimation of pressure dropping during hyperemia from a standard CCTA with a high accuracy and agreement with an invasive FFR. What is its role in guiding coronary revascularization actually?
So I think that particularly in the intermediate lesion in terms of anatomy, and of course in the calcific lesion where CTA has been demonstrated to make sometimes an overestimation of the true severity of the lesion, FFRCT may help in identifying the functional relevant stenosis. And the major advantage for intervention is that it's a bit lesion specific. So you can assess millimeter by millimeter the value of FFR and the drop across the lesion. Nowadays, apart from the absolute value and the end of the vessel, the delta across the lesion, more than 0.1, has been associated with a particularly relevance of this type of stenosis in terms of from a functional point of view.
Mm-hmm. And what about CT-MPI? As we know, compared to CCTA alone, the addition of CT-MPI improves the diagnostic accuracy for the functional assessment of coronary artery disease. The reported sensitivity and specificity yields between 82 to 92 and 73 to 86% respectively. Can contribute in patients with untreated CAD and in revascularization patients too?
Yeah, of course. So I think in comparison with FFRCT, the major advantage of stress myocardial CT perfusion is that this is an inside method. So then it's cheap, does not require external correlate, and of course allows for identifying functional significance of a lesion in both native coronary arteries, such as FFRCT, but also in already revascularized patients. This means stent or CABG patients. Of course, as drawback of the method, we have to underline that both modalities, static or dynamic CT perfusion, account for more radiation exposure and more contrast agent than the standard anatomical CTCA.
Okay. And then another aspect dealing within the document are the chronic total occlusion, defined as occluded coronary arteries with a TIMI score of 0 and with an estimated duration of above 3 months. The prevalence of this finding among patients referred for CCTA is low, of about 1.54%. The reason is clear, though. Can we take advantage of performing a CCTA in patients with CTO and maximize the procedural success?
Yeah, so I think also reviewing the literature for preparing this consensus document, probably the field of CTO PCI is the one more represented in the literature. And there are very initial studies that documented that the CTA allows to identify some lesion characteristics that can be associated with less procedural success. These include, of course, the extent of calcification at the entry site of the CTO, the length of the CTO, the tortuosity of the occluded vessel, but also some collateral branches that can start in the occluded portion. And then, of course, we have the opportunity to analyze these factors before deciding to try with a CTO PCI. Moreover, some good prospective and randomized studies documented that the approach CT-guided has been associated with more procedural success, in particular in very complex CTO in terms of the anatomical score, for example, the JCTO score. So has been documented that in this particularly complex anatomy, to have for the interventionalist a roadmap provided by CTA may enhance and improve the rate of CTO PCI.
And the limitations or evidence gaps, in your opinion, Professor?
So I think that we have interesting studies that we also underline in our document. For example, the syntax studies, syntax 2, syntax 3, showing that CT, coronary angiography, may be useful also at the apex of the pyramid of coronary artery disease, so in intervessel or left main coronary artery disease patients, for helping an RT in the decision-making between a PCI or CABG as actual treatment. Otherwise, I think that nowadays we need to have a randomized trial. So we need to have a randomized trial that try to compare the standard of care, so the standard PCI, with a CT-guided PCI. So a PCI that can be supported by a CT performed before invasive angio, again, to try to provide the interventionalist on information also that allows to select the material, to select the right personnel. As you know, if you have a distal left main bifurcation, if we have a long CTO, if we have a multivessel patients, the specific people and material need to be selected to do this type of PCI. Otherwise, what is the major lack in the literature review nowadays is to demonstrate that this approach may be really useful in the clinical practice.
So finally, Professor Andreini, any ongoing trials that we must be aware of?
Yeah, I will mention a couple of trials. One in the very intriguing field of planning a CABG procedure by a CTA approach only. And I have to mention the fast-track CABG trial. It is coordinated by Professor Sarais and is nowadays ongoing. 2/3 of the population has been enrolled, and the initial findings are very positive because the feasibility endpoint, so the capability of the surgeon to plan the vessel to be treated and the landing zone of the CABG by using CTA alone is 100% at this time. And then, of course, we will see the final results in 1 year, more or less. And I will also mention the P4 study, that is a randomized clinical trial with the team of Alst, Carlos Collen, Bernard de Bruin. We are randomizing patients with more than 70% stenosis at CTA and CT-FFR showing a value of below 0.8 to a standard of care, so to the IVUS-guided PCI versus the CT-guided PCI approach. CT-guided PCI, that means that the interventionalists receive a so-called CT package that include a lot of parameters, including the ostium location, the plaque characterization, the lesion quantification, the CT-FFR, and the real-time guidance into the cath lab versus the standard of care. The primary endpoint of this trial is a clinical one, and is the non-inferiority of CTA approach. So the results of this trial will be available in a couple of years.
Mm-hmm. So thank you, Professor, very much for all these interesting things. And it was a pleasure, a really pleasure discussing with you all this stuff.
Thank you very much. And I also thank you, of course, to the first committee. That is a very nice committee of SCCT. And thank you for your very good activity in the society.
Well, listeners, I hope you enjoyed this episode. Thank you, as always, for tuning in. Remember, if you like what you hear from us on the podcast, please rate, review, and subscribe. For even more educational content, consider becoming a member of the SCCT if you aren't already. This is the Donut of Destiny. Cheers.